So my talk is a grandmother story in front of them, but still sometimes we like grandmother stories. As you know, diabesity is a new world syndrome. It is not just about weight or just about overweight or obesity. It is a it is recoined as adiposity-based chronic disease. It's a disease by itself if it fits into the diagnostic criteria. So rising type 2 diabetes in India in adolescents, actually the disease used to be grandfathers and grandmothers, is now grandchildren's. Anybody know that who is the what is the age of earliest diagnosis of type 2 diabetes in children? 4 years. So adolescents and childhood diabetes is increasing as such. What has changed actually in the last 3 decades? Obesity in adolescents and children has increased by 4.5 to 5 folds. What exactly has changed? There are about 2,000 Domino pizzas. There are about 700 KFCs, 700 McDonald's, etc. At the end of the day, most common cause of obesity in the children and adolescents is genetics. Genes constitute up to 60%, but genes don't change even after 100 years. So what exactly changes is the epigenetics from the environmental causes. So in front of us, there are a lot of obesity, a lot of diabetes is going to increase further. And the drivers of youth onset type 2 diabetes is, there are too many. Nowadays, as I told, the fast food outlets, one need not go to the theater, and the video games, etc., has increased in the recent past 3 decades, possibly driving the children and youth to get more and more diabesity. So this is one of the challenging, unless you control the childhood diabetes, all these are going to be potential candidates for the adult diabetes, as well as the consequent complications of cardiovascular disease, heart failure, cancer, etc. So obesity is not just a cause of a few problems. It is responsible for 229 complications related to obesity and about 13 cancers associated with obesity. So to prevent all this in adult, we have to take care at the child and adolescent age. So management of overweight, obesity in adolescent diabetes. So this is only in diabetes. So lifestyle, as you say, everybody advocates, nobody follows. Pharmacological therapy, then weight management strategies and comprehensive care all put together. So now ADA recommends, here ADA recommends GLP-1 agonists or SGLT2 inhibitors after lifestyle and the metformin as after metformin. Now even 2026 recommends as first line drug. And there are few challenges in the management of type 2 diabetes in adults. There is poor compliance and failure of metformin and the lifestyle medication. It's not the failure of metformin. Metformin fails slowly. The fellow gets doesn't respond to he fails to respond to metformin actually. So starting basal insulin is recommended by a study called Today study. So why GLP-1 RES in adolescents and childhood obesity? One, it has a powerful beta cell conservation. Two, metabolic benefits of glycemic benefits and weight benefit. And of course, we know the ectopic fat will reduce and the cardiometabolic risk reduction happens, and safety is proven. Let us see in detail. And early use may provide long-term protection because These are the children who are going to live long with diabetes. So, what is the role of GLP-1 RAs in managing diabesity? It is actually as multifactorial, it works on every factor. What exactly causes the obesity? One is the appetite center is suppressed and satiety center is stimulated. So GLP-1 agonist controls the appetite and improves the satiety. And also at the mesolimbic system, there is a center in hypothalamus which regulates your behavior of eating, which is regulated by leptin. So this almost controls all these pathophysiological factors which are caused by obesity, and of course the inflammation related to the ectopic fat, that is the epicardial fat, the hepatic fat and peripancreatic fat and so on. So what is the clinical evidence of GLP-1 RAs in children and adolescents? So this is a review or meta-analysis of safety of these drugs in children. So safety and efficacy, you can see here HbA1c control much better. You can see here the fasting plasma glucose and the other parameters like body mass and BMI, percentage of BMI and BMI, relative BMI or absolute BMI, both are consecutively reduced, and the triglycerides and other associated pathophysiological mechanisms that are associated with obesity. What is the clinical evidence on? This is a very ELLIPSE trial, is a landmark trial, actually was done among the children and adolescents. This has shown conclusively that liraglutide can reduce the A1C control quickly and maintain over a period of time. So glycemic benefits. You can also see here liraglutide was associated with statistically significant reduction in BMI, which weight, and the parameters at about 52 weeks. So these are the results. Results has shown that weight, BMI, and the fat percentage, fat mass, all this has improved. Liraglutide has effect in children and adults. So significant reduction A1C and triglyceride and lipid profile. So literally there is a therapeutic paradigm shift that treatment with liraglutide could be useful in therapeutic options in pediatric obesity in patients who have not achieved significant weight reduction with conventional interventions. So this is impact of liraglutide on metabolic comorbidities, reduction of BMI, reduction of blood pressure, and also the lab parameters like dyslipidemia, liver enzymes, etc. will come down. When to initiate liraglutide? In which patients? Liraglutide is FDA approved for type 2 diabetes, adults and children also. This is the only drug approved for adult and children diabetes above the age of 10 years. And the dosage to start is 0.6, and it has to be escalated, is a daily subcutaneous injection. As the patient tolerates, it can be escalated to 1.2 and further up to 1.8. So adverse events are not very many. They are like any other GLP-1 agonist: nausea, vomiting, abdominal discomfort, diarrhea, etc. There is a study here, you can see. This is a meta-analysis of many studies, including 4 RCTs, has shown this is the age between 6 and 18 were studied. There are no trial at all between 6 and 8. Of course, FDA has not approved for above the age of 10. So this data is very recent data and it's pending for the approval. So as you know, the how to initiate, when to initiate, and when to escalate. So to conclude my talk, childhood obesity and adolescent obesity are going to be adult obesity. So it is very important to catch at this point, and there are no effective drugs so far. So early comprehensive approach combining lifestyle modification and pharmacotherapy is essential. And lifestyle adherence, since it is difficult, behavioral participation is difficult for the patient, it's prudent to go with the medication as early as possible if indicated. And metformin remains the first drug, and liraglutide plays a key role in the population proven to have reduced A1C with body weight. How low hypoglycemic risk is approved above the age of 10 years. Liraglutide therapy improves BMI, blood pressure, and various other pleiotropic benefits. Thank you very much. I'll be happy if